Okay, let me walk you through some practical biopsy tips and tricks. As I mentioned, biopsies are very common and essential part of clinical practice. We want to discuss each type of biopsy in detail here, like lung or liver biopsies, as those will be covered separately. But today we will focus on the general principles and techniques that apply to most biopsies. Okay. So the first thing to remember is that not all specimens are the same. Okay, so knowing the clinical suspicion is very important. Okay, most biopsy samples are preserved in formalin for histopathological examination. However, some specimens require special media other than formalin. Okay, for example, in cases, say, of lymphoma, okay, flow cytometry studies may be required to accurately identify the exact type of lymphoma. These samples should not be placed in formalin, but preserved in a special medium such as RPMI, although the medium may vary depending on your institution. It's very important to keep this in mind before taking a biopsy. Okay, as imagine taking a biopsy from a very challenging location, and after taking this precious sample and sending it to the lab responds back that the requested test cannot be performed because the specimen was placed in the wrong medium. Okay, so what should you do in these situations? As mentioned in the first day IR episode, keep trusted pathologists' contact details saved on your phone. If you receive a sample from a specific lab, simply ask which medium they prefer. If that is not possible, contact a trusted pathologist to confirm the appropriate medium for the sample. Okay. Now, let's move to point number two, which is regarding the formalin again. Okay, there is an important rule. As mentioned before, we usually obtain three biopsy samples so that if the first sample is suboptimal, the second may be better, and the third can serve as a confirmatory sample. Formalin is kept usually in a cup like this. Okay, a very important point is that the tip of the needle should never touch the formalin and then be reinserted in the patient. In other words, if you have obtained a good sample here, okay, you should never use the needle to wash out the specimen into formalin like this and then reinsert it back into the patient. Because formalin is a very irritating agent, doing that can lead to infection and sometimes even tissue necrosis. Okay. Also, there is no such thing as whipping it off and use it again. Okay, this is not recommended. What you should do instead is either use the tip of the needle or a scalpel to gently transform the specimen onto the blade. Okay, the blade, then place it into formalin. In some biopsy sets, there is a plastic device designed to help you to transfer the sample safely. So again, please don't place the needle in formalin and then reuse it on the patient. Okay, another important point is that these needles operate with a clicking sound, okay, which is very important to note. As physicians, we are familiar with the clicking sound the needle makes, but always remember that the patient does not know this. So, if you are performing, say, liver biopsy and the patient was not informed beforehand, the sudden clicking sound may startle him, causing unexpected movement that could result in self-injury or procedural complications. So, it's very important to speak with the patient before you begin taking the biopsy. If the patient can't tolerate seeing the needle, you may show it to him and explain that it makes a clicking sound during sampling and that click is not painful. On contrary, it indicates that we are in the right position and successfully obtaining the sample. But of course, if the patient is afraid of needles, it's not necessary to show him the needle itself. So it's very important to prepare your patients for the procedure. Another key point before you start the biopsy, make sure you know the depth of the lesion you are targeting using either ultrasound or CT scan. So, let's say this is the liver here, okay, and this is the anterior abdominal wall, and here is your target lesion. Let's say the lesion depth on the CT scan was about 5 centimeters deep. It's important to be aware of this information, especially in early stages of practice, so you can accurately anticipate the target lesion depth. So if the lesion is 5 centimeters deep, we can use this coaxial needle and set the marker to 5 centimeters before insertion. And on inserting, the needle will stop at 5 centimeter mark. Okay. If that marker is not available or you prefer not to use it, you can rely on the scale here. It's 1, 2, 3, 4, 5. Grip the needle at 5 centimeter mark, then insert it. As soon as you reach 5 centimeter, your hand will naturally stop you. I'm mentioning this because it's one of the most dangerous issues we often see, especially among residents and during the early stage of training. When we can't see the needle clearly, there is always a tendency to push further. It can feel like we still haven't reached the target, so we keep advancing the needle. This can lead to serious complications. For example, if a resident is having difficulty during a biopsy and I step in, we find that the lesion is at 5 centimeters while the needle has already advanced to 9 centimeters. In this situation, stop immediately and reassess the needle position. Okay? As it may have entered an unintended area, risking vascular injury or other complications. So, it's very important to have a very good orientation regarding the depth of the lesion from the beginning. If you reach 5 centimeters and you still cannot visualize the needle, stop, reevaluate, because most likely something is wrong. Another important point is that your best chance of obtaining good sample is usually with the first or the second attempt. After the second sample, the chances of getting a good quality sample decline, and this is for specific reasons. Let me explain this concept with two examples. Okay, the first one, taking a biopsy from the lung. Let's assume this is lung tissue, and your lesion is located right here. Here is lung tissue, and these are the airways. The lung tissue is known to be highly vascular and it tends to bleed easily. So, after taking the first sample, you may notice some bleeding like this. With the second sample, the bleeding can increase further like that. By the third attempt, bleeding may become severe enough to obscure the lesion. That's why, as I mentioned, you should take your time with the first and second samples, as they offer the best chance for accurate lesion targeting. After that, a lot of changes occur that make visualization of the lesion challenging. The same principle applies to the liver biopsy, where a coaxial needle is usually used. Okay, each time you advance the coaxial needle, you remove the inner stylet and insert your biopsy needle. You introduce air as well. So, some echogenicity starts to appear within the lesion. As the echogenicity increases, visualization becomes more difficult, especially if you are performing the biopsy under ultrasound guidance. So, don't rush. Beginners often feel the need to take samples quickly. Take your time with the first and second samples, as they offer the best chance for a good quality sample. Another key point is needle size, which you will frequently encounter at the beginning of your practice. Biopsy needles come in different sizes, measured by gauge. For example, we have 14, 16, 18, and 20 gauge. Okay, as you may remember, the higher the gauge number, the smaller the needle size. This depends on the place you practice in, but generally an 18 gauge needle is most commonly used for biopsies, as it provides a good balance between obtaining an adequate sample size and minimizing tissue trauma. But if you go for a 16 gauge needle, you will obtain a larger biopsy, but the risk of bleeding may be slightly higher. On the other hand, using 20 gauge needle gives a smaller sample but with a lower bleeding risk. As mentioned, this depends on your practice. However, 18 gauge is the most commonly used. Some clinicians prefer 20 gauge needles in lung biopsies because lung tissue tends to bleed easily. Others may choose 18 gauge to obtain a better quality sample, accepting the increased bleeding risk. It all comes down to the place you practice in. Okay. Another important point is deciding which part of the lesion will be sampled. Okay. Let me give you an example. Say we have any plastic mass like this. Okay. The lesion usually starts small with an initial blood supply, then grows outwards. As it enlarges, it develops new vascularization from the periphery. So, blood supply will be rich at the edge, okay, and relatively poor in the center, and this results in central necrosis. The central necrotic area is not ideal for biopsy, as sampling it may lead to a pathology report stating necrotic tissue not enough to make a diagnosis. The problem here also, especially early in practice under ultrasound guidance, is that this area may looks like the ideal target for sampling because the needle is highly echogenic and the necrotic part is more fluid-like, therefore appears hypoechoic. So the detailed target visualization becomes easier. However, it is not the best area for sampling. The more appropriate target is usually the periphery of the lesion, not the center or the deep center of the lesion. In the past, this was considered an absolute rule, but now we can even see it on PET scan. On PET CT, the periphery is usually the hot area. Okay, so these are the areas that are better for biopsy rather than the center. Okay, that's why it's very important before performing any biopsy to review the previous imaging. Okay, from these images, you can identify the best site for sampling, determine the optimal approach, estimate the depth, and decide the appropriate needle length you need. Okay, this is another important point. You should guide your technician as regard the needle length you plan to use. For example, if the lesion is about 6 centimeter deep, usually, a biopsy needle with a 10 centimeter coaxial needle length would be sufficient to reach it, okay, leaving you with an extra 2 to 3 centimeter margin. But if the lesion is 15 centimeter deep, a 10 centimeter coaxial needle won't reach the target, and you will need to switch to a longer needle. All these factors should be planned before starting the procedure, and we will cover them in more detail in specific organ biopsies. So, if you have a PET CT or CT with contrast, you should look for the enhancing part of the lesion. That is the area you should target for biopsy. Now, if the lesion was not like this, okay, and you advance the coaxial needle, then on withdrawing the stylet, you notice fluid coming out. Since you are already in that position, okay, the recommended approach is to connect the coaxial needle to a syringe and aspirate the fluid, say take around 5 cc. Okay, this sample can then be sent to the lab for cytology as it may be sufficient to identify the type of cancer. Okay, while you are in this location, you can also slightly adjust the position of the coaxial needle up, down, side to side to obtain samples from different areas. Sampling from multiple sites increase the diagnostic yield. However, surprises can occur. If you enter the lesion and find fluid, aspirate it, okay, and send it for cytology. Don't discard it. Okay, another point I'd like to discuss is biopsy in some special organs. I'm mentioning this early so that you become aware of them before we discuss them in detail. Let's first talk about lung biopsies, okay, especially when the lesion is very peripheral like this, okay. Here is the bronchi, this is the lung on the other side, and this is the chest wall. Now, if we are advancing coaxial needle like this, okay, we may reach the target and take our biopsy, okay, no problem. But afterwards, the needle might shift into the pleural space instead of remaining within the lung. The problem is that if this happens and you remove the inner stylet, okay, and without realizing it, okay, you place the patient at a high risk of developing pneumothorax. As soon as the patient takes a breath, Negative pressure is generated in the pleural space, air enters the pleural space, and pneumothorax sign occur. This often occurs right after sampling, okay, when you are assessing the adequacy of your specimen. So you are inspecting the sample, leaving the needle open. This creates a very high risk of pneumothorax. So how can we avoid this? It's very important before withdrawing the coaxial needle to make sure you have a good seal here, okay, at this part. How do you achieve that? If you are working with an experienced technician, you will usually find that he always have a saline syringe ready on the table. The idea is that while you are withdrawing the stylet, the assistant immediately places few drops of saline on the tip of the needle. So as soon as the stylet is removed, there is a small drop of fluid at the tip here, okay, which act as a valve preventing air entry. Therefore, it's very important to maintain this seal. After withdrawing the needle, reinsert the stylet, okay, halfway into the coaxial needle to seal the tract and prevent air movement in or out. As you proceed to the next sample, remove this and immediately place your finger over the hub to prevent air entry. Then reinsert the needle as usual and take the next sample. Once you are done, as you withdraw the needle, someone applies saline to the tip of the needle, as you can see. Okay. As soon as the needle comes out, place your finger over it again, reinsert the inner stylet midway like a plug, preventing air entry. These simple steps can make a great difference, especially in such situations. Okay, now let's move to another important organ, which is the kidney. The kidney is one of the organs most prone to bleeding during biopsy, which is expected because it receives about 20 to 25 percentage of the cardiac output, roughly around 1 liter of blood per minute. So it's very common to encounter bleeding while performing the kidney biopsy. And my advice is that if you have never performed biopsies before, don't start with kidney biopsy without experienced supervision, as the amount of bleeding can be sometimes scary, okay, and intimidating, especially for beginners. But this is the nature of the organ. It's very vascular, so bleeding is expected. Now, how do we deal with this bleeding, which is likely to occur? There are several options or approaches. If the biopsy needle is placed like this and we withdraw it after taking the sample, there may be significant bleeding here. We can use agents such as Surgiflow, which is hemostatic gelatin. It comes in a powder form and is mixed, as you can see here. After mixing, it turns into a gel-like substance. Now we can connect the syringe to the needle and then begin injecting it as we come out, okay? So it looks exactly like this. It's placed in the kidney and I start injecting. I hope it's visible on the camera. The gel starts to come out as I withdraw step by step, effectively blocking the track. This is a gelatin material that acts as a scaffold for platelets to accumulate and form a blood clot. So, what's the advantage? As mentioned, it immediately stops bleeding and it's temporary, as it's completely absorbed after 4 to 6 weeks. My advice is that if it is available in your place, don't overdo it. Just use enough to line the tract and stop bleeding. Don't overdo it because if it enters the bloodstream, it may cause serious complications. Okay. Now, let's say Surgiflow or similar hemostatic agents are not available in your place. Another option you have probably heard of is the gel foam. Okay, it's commonly available in most IR places and comes in different forms. It can be mixed in a way to create slurry, what we call a gel foam slurry, which can be injected. We will discuss gel foam in details with embolics, but for now, it's important to know that if other hemostatic agents are not available, gel foam is usually available in IR suites. Okay. Now, if neither gel foam nor any hemostatic agent is available and you are dealing with bleeding, what should you do? You can use a modified technique that was previously used for hemostasis. In the past, some practitioners would draw 5 cc of the patient's blood in a syringe, leave it until it clotted, then use this clot as a hemostatic agent. Some people still use this technique, although it has become less common with the availability of modern agents. Okay. However, we can apply a similar idea. Okay. Let's say this is the coaxial needle, okay, positioned inside the kidney like this, and there is some bleeding here, okay. In this case, you can insert the stylet and leave it midway for a few minutes, let's say around 5 minutes, okay. The idea is that blood enters the needle lumen, but stops due to the plug here, okay. This allows clotting to occur within the needle lumen itself. Over time, complete clotting occurs, and when you remove the needle, there is no active bleeding. In this case, you can simply advance the formed clot inward and then withdraw the needle. Again, if you have no other options and the blood is seen through the needle, you can use this technique as a hemostatic agent. Now, after everything we have been through, if you notice, many complications occur after you have already taken the sample and left the needle like this. Okay? As you become satisfied, so your attention shifts to checking the sample while blood escapes or air enters. So it's a good practice that as soon as you withdraw the needle, immediately insert the stylet halfway and leave it in place. This simple step can prevent many complications. Okay? Another point I'd like to discuss with you is whether to take 1 centimeter or 2 centimeter biopsy. We have talked about this before, but I wanted to clarify it further. Of course, sometimes there are certain limitations, okay? But it's by logic, a 2 centimeter sample is better than 1 centimeter sample because it provides more tissue. That's right. But sometimes the lesion itself is already 0.9 centimeter. You simply don't have the option of taking 2 centimeter sample, okay? But if the lesion is 5 centimeter, a 2 centimeter sample would be more appropriate. The 1 centimeter sample is generally not preferred by pathologists for 2 reasons. First, it's simply shorter, okay, and provides less tissue than 2 centimeter sample. Second, which is a very important point, it tends to be fragmented. Pathologists usually prefer receiving one piece like this, okay? When the sample comes crumbled or fragmented, that's not ideal for the pathologist. That's why we always try to ensure that at least 2 out of 3 samples are intact like this. But why does fragmentation happen? It occurs due to some factors we have mentioned before and we will readdress again. It's not only related to the sample length, but also the spring force. A stronger firing mechanism improves the sample quality and reduces fragmentation. So the question is, can we obtain 1 centimeter biopsy using the strong spring force of a 2 centimeter needle? The answer is yes, we can. In the past, this was done manually. Nowadays, companies have developed devices that allow for more precise sampling. Now, let's talk about the modifications companies have introduced to improve biopsy sampling. This is the coaxial needle through which this needle is inserted. Now, if we set the needle to 2 centimeters and advance it through the coaxial needle until it is hub, I mean by hub that this part reaches here. Firing the needle will allow the 2 centimeter notch to obtain a 2 centimeter sample. Now, let's talk about the rule of this cap, okay, which I intentionally left until the end. And for our technician colleagues, remember, every component in the set has a purpose. Many people may throw these parts away because they don't know their use. So my advice for new IR technicians, if you don't know the use of any component, ask someone more experienced or even contact the company representative. This piece is 1 centimeter long, okay, and we attach it to the hub. So we effectively are adding an extra 1 centimeter here. Okay. So now if I set the needle to 2 centimeter and advance it to the hub, I'm actually hubbed with the blue piece. That means I'm still 1 centimeter away from the original needle hub. As a result, that extra 1 centimeter is subtracted from the notch here. So when I push this out, you can see that only 1 centimeter is exposed. There is still 1 centimeter inside. But adding the blue piece shifts the whole system back by 1 centimeter, leaving only 1 centimeter exposed while the other remains hidden inside. The hidden portion will not take the sample because it is not exposed. Okay, only the visible 1 centimeter notch will capture the sample. This means I can obtain 1 centimeter biopsy while still benefiting from the stronger firing force of the 2 centimeter spring mechanism. As you can see, okay, it's the same powerful 2 centimeter spring, but giving me 1 centimeter sample. So, are there any other modifications? Yes, there are newer biopsy needles available, like the one I'm about to show you. Okay, here this needle is from Argon Company. It's called the Supercore Advantage, the older model called Supercore. The Supercore Advantage applies the same concept but in a more fancy way. The design is slightly different to improve ergonomics and make sampling easier. We now have a built-in option to select the sample length. So I can pull the needle back one click. Okay. Here it's marked 10 millimeter, which means 1 centimeter sample. Then take the sample like this. Or I can pull it 2 clicks, which corresponds to 20 millimeter or 2 centimeter. And as you can hear, okay, there is a difference between clicks. Now we can apply the idea we discussed earlier. Set the device to 2 centimeter spring setting. Then use this adjustable part, which moves like this. Okay, can move like this. And I can set it to 1 centimeter. So I'm still using the stronger 2 centimeter sample mechanism, but adjusting this part to 1 centimeter. So only 1 centimeter will be exposed. As a result, I can obtain my biopsy sample. Actually, all these modifications are useful, but you may not always have access to these advanced devices. So, when you got this piece, make sure not to lose it, as you still can perform the same technique manually. In fact, that's how we did it before these newer devices were available. Okay, just set the needle 2 centimeter and insert it through the coaxial needle, but instead of being hubbed, stop 1 centimeter short. So you are manually doing the same job of the blue cap or this component. You does it for you. You maintain 1 centimeter cap so that when fired, only 1 centimeter is exposed outside. This gives you 1 centimeter biopsy while still using the 2 centimeter spring force. As you have noticed, this technique requires a certain level of experience. You need to maintain 1 centimeter distance, and the problem is that while advancing the needle, you may accidentally lose this distance. Once that happens, you have switched to 2 centimeter biopsy, and that won't help if you want to obtain 1 centimeter sample. That's why I always say it's better to use the dedicated devices whenever possible. If you want to try this maneuver, okay, practice it first in a superficial or low rest case. And always keep your eye on that 1 centimeter. Don't lose it. Don't lose it during needle manipulation. Okay. Now, one last technique to maintain. Okay. To mention, which is the curved needle technique. So you can recognize it if someone talks about it. Okay, let's assume we have a lesion like this, okay, with a necrotic portion here, and I wanted to take a biopsy from it. First, we insert the coaxial needle as usual, okay. If we advance it and try to sample from here, we will end up sampling the necrotic part. No matter how many times we advance in this trajectory, we keep entering the same area because everything is straight, even with repeated attempts. If I want to obtain a biopsy from other areas of the lesion, I have to redirect the coaxial needle slightly up and down. And in some cases, moving the coaxial needle is not that easy. In such situations, okay, a modified technique is used where We push the coring needle out and then bend it slightly outward. We bend it about 25 to 30 degrees, okay? We want to give this needle some direction because as long as it is straight, it will just go in a directionless way. Also, it's very important that I bend it outwards, not inwards, okay? So the notch should always be on the convex side of the curve, okay? So I'm bending the needle now, like you can see this, okay? I hope it's clear on camera. Now I can take my biopsy because the curve isn't strong enough to ruin the needle. At the same time, it gives me direction. Okay, let me explain this to you. Assume this is the lesion like this. Okay, then when I position the needle in this direction, okay, I'm sampling here. If I redirect it away, I will sample different area. And it's very important to always ensure the curve is directed outward. Okay, I mean the needle should always be shaped like this. The notch should face outward, not inward. Okay, because otherwise the spring mechanism may not function properly. Okay. Okay, and if you overbend the curve beyond the acceptable limits, you may damage the needle's mechanism. I showed you this technique for two reasons. First, you might direct the needle right or left, so obtaining biopsies from areas other than the target lesion. Second, some argue that samples from the curved needle are of better quality than those obtained from straight needle, although this is a matter of debate. Personally, I have only used this technique maybe 4 to 5 times because in most cases I can reach the target area by maneuvering the coaxial needle. With that, we have reached the end of this episode of IR Pathway. I hope it helped you to understand some important biopsy concepts. Thank you very much, and I'll see you in the next episode. Goodbye.